Everybody learned about the thrombolysis in acute stroke management. Now we'll go on for mechanical thrombectomy or endovascular therapy in acute ischemic stroke. As all of you know, time is brain, every minute counts. If you delay the reperfusion, it will lead to death of multiple neurons. Here it is estimated that per second, at around 32 seconds of neuron will lost, synapse around 230 million synapse will be lost, and myelinated fibers at around 200 meters will be lost, and accelerate the aging by 8 to 7 hours if you delay the treatment for only 1 second. And if you delay furthermore, it will increases the neuronal death and the age of aging. In ischemic core zone, blood flow is around less than 10 to 25% of the cerebral blood volume. This leads to consequent loss of oxygen and hypoglycemia that leads to the necrosis of neurons and glial cells. That will lead to poor outcome. What is the need of endovascular therapy? As all of you know, tissue thrombolysis, there will be narrow window. Only for if a patient comes within 4.5 hours, that time only we can do thrombolysis. Beyond that, we cannot do thrombolysis. And in some patients, like recent surgeries, coagulation abnormalities, past history of any intracranial hemorrhage, in that patient also we cannot do thrombolysis. And in case of large vessel occlusion, thrombolysis will not be effective. So that case also, mechanical thrombectomy or endovascular therapy plays an important role. And early recanalization after tissue plasminogen activator only occur in 1/3 of the patients. In rest of the two-thirds of the patients may need other modalities of reperfusion. So in these cases, we need these are the indications for endovascular therapy. This is very important if in a case stroke with slow progression of the symptoms, wake up stroke, and duration of the stroke is not known. And in case of large vessel occlusion, in these scenarios, endovascular therapy plays an important role. This extended time window, usually for thrombolysis, it is 4.5 hours. For mechanical thrombectomy, it is up to 24 hours after the stroke. This is called extended time window for reperfusion. It is indicated in core clinical mismatch. Like if the infarct size is less, salvageable penumbra tissue is more, that scenario patient will be having deficits that is inappropriate to the your imaging findings. That is called core clinical mismatch and core penumbra mismatch. Like if the ischemic core is less than penumbra, that is called core penumbra mismatch. And third one is diffusion flare mismatch. As I told earlier, in a case of wake up stroke, if patient had stroke, the duration is unknown. In that scenario, if flare images not developed any edematous changes or any hyperintense signal, that time also you can do thrombolysis, because flare images edema to develop, it will take around 4.5 hours more than 4.5 hours of duration to develop edema. In these three settings, we can do reperfusion therapy. Any doubt in this slide? This is very important slide. If you are having any doubts, let me know. Clinical mismatch, core penumbra mismatch, diffusion DWI flare mismatch. These are the three predictors for mechanical thrombectomy. Shall we go ahead?
Yes, sir.
Okay. The newer concept is tissue window. All of you know thrombolysis, the window period. This is tissue and this is called tissue window. It is recommended up to 24 hours from the symptom onset. From the stroke to 24 hours of symptom, from stroke onset to 24 hours, we can still reperfuse the tissue by doing endovascular therapy. Penumbra, as all of you know, this is described as the area of brain tissue that is still viable, but is critically hypoperfused, and it will progress to infarct if you don't treat at that time. Okay, this is the salvageable tissue. If you don't treat, this penumbra will convert into ischemia, and this will lead to permanent deficits. All this tissue window is decided by collateral blood supply depending on the cerebral perfusion pressures, susceptibility of the tissue for ischemia, location of the blood vessels, and some of the metabolic parameters like hyperglycemia, hyperthermia, and CO2 narcosis. Initially it was done like initial trials they did with the intra-arterial fibrinolysis. Now recent concept is mechanical thrombectomy. These are the two wide modalities of mechanical thrombectomy. We'll go to the mechanical thrombectomy in detail. When will you consider for mechanical thrombectomy? If you receive the patient in the emergency, can anybody tell NIH, what is NIH score? Briefly, kindly someone tell what is NIH score? Last class I have told, I think. Anybody? I'm not asking the long form. What is this concept of NIH score? Can anybody tell?
Sir, the level of consciousness, uh, LOC, visual level, spatial palsy,
Hmm.
motor arm and motor leg grading, and
Okay.
this is present,
Hmm.
and language, dysarthria, and sensory system.
Okay. Hmm.
It is graded into different.
According to the severity, and numbers will be given. Highest number would be 42.
Yes.
Okay. If the score, what is minor stroke? Last time I told you. If NIH score is less than, if the NIH score is less than 5, it is called minor stroke. If it is more than
6, it
5,
is
uh-huh.
large.
Hello. Tell me.
Sir, if it is more than 6, then
It is major stroke. Okay. These are the common terms we'll be using in the next slides. Okay, that's why I'm asking you. NIH score is National Institute of Health Stroke Severity Score. It contains all the parameters like consciousness, language, weakness, ataxia, sensory symptoms. The grading will be given according to the severity. If the number is more, that indicates severity is more. If the number is less, severity of the stroke is less. The threshold of NIH score 10 or more than 10 equal to it indicates almost there is chances of large vessel occlusion. If a patient in the emergency, if you see NIH score is more than or equal to 10, it indirectly indicate large vessel occlusion on the clinical basis. You should be alert enough. After thrombolysis, you should be planned to transfer the patient to the center where the availability of the mechanical thrombectomy is possible. Okay, NIH score cutoff is more than 10. If you decrease the NIH score more than 6, it has a sensitivity and specificity of 87 to 52% respectively. Ideally, CT angiography would be better accuracy as compared to MR angiography. Angiography that gives approximate around 87 to 100% estimation of your vessel occlusion. Gold standard is your DSA, that is the digital subtraction images. DSA images are gold standard. In our setting, we can do CT angiography or MR angiography to confirm whether the patient is having large vessel occlusion or not. Okay, if you are clinically suspecting large vessel occlusion, kindly get angiography done so that we can plan for the further evaluation. Like other scans we can done in our setup is like non-contrast CT, head and neck angiography of CT, CT 4D imaging, and brain perfusion studies. And one more study modality is perfusion imaging. This is done if a patient who presented to emergency after the 6 hours of onset of the stroke. If patient comes within the 6 hours, there is no need of doing the perfusion scanning. to assess the penumbra, because before 6 years, almost the tissue which is present is penumbra. Penumbra will be more as compared to ischemic core if the patient present within 6 hours of onset. In that time, after doing CT angiography, you can directly shift the patient for mechanical thrombectomy. If a patient present after the 6 hours, you need to do CT perfusion scanning. So CT perfusion scanning, it contains like CT, normal CT only with the contrast, and the nuclear medicine department will take the important role to identify the perfusion, this perfusion parameter. This contains three perfusion parameter: mean transit time, cerebral blood volume, and cerebral blood flow. Only one thing you remember: cerebral blood volume. Cerebral blood volume is defined as the total volume of the blood flowing in a given volume of the brain. This is always decreased in ischemic core, and it will be normal in penumbra. These only one parameter will help you to decide whether the salvageable tissue is more or ischemic penumbra, ischemic core is more. So cerebral blood volume, you remember, in a perfusion scanning measure, what we see is cerebral blood volume. If cerebral blood volume is decreased, that indicate ischemic core, and if cerebral blood volume is normal, that indicates penumbra. So penumbra, the patient, those who are having penumbra, will be the ideal candidate for mechanical thrombectomy. Before going to the mechanical thrombectomy procedure, these are the common terms you are using, like NIHS score, aspect score, and MRS score. These three you should be knowing. As a physician, you should be knowing these three. Okay. When you get the CT done in the emergency department, you see, you divide the CT slices at the basal ganglia level and supra basal ganglia level. Supra ganglionic level, this is called. This is at ganglionic level. You divide. This is a caudate. C for caudate, IC for internal capsule, L for lentiform, and I for insular cortex. M1, M2, M3 are middle cerebral artery branches. That is, if it is adjacent to the insular cortex, this is called M2. In front of M2 is M1, and beyond M2 is M3. And the supraganglionic level, M4, M5, M6. These are the same segment. Above the M1 is M4, above the M2 is M5, and above the M3 is M6. Whenever the stroke patient comes, you see patient is having right hemiplasia. You see the left hemisphere, and you see for these structures: 1, 2, 3, 4, 5, 6, 7, 10. Total 10 in a number. Okay. If, say for an example, patient is having infarct in the caudate lobe, so you need to subtract the number from the total number. Total normal number is 10. If patient is having caudate lobe infarct, it will come under 1. So 10 minus 1 is equal to 9. This is the aspect score of the patient. Okay. If a patient is having infarct in the M1, M2, and M3, you need to subtract from the 10. So 10 minus 3 indicate it will come around 7. Are you following? Hello?
Yes. Yes, sir.
Okay, total 10 in a number. 10 is the normal number. Normal person, patient will be having the 10. If the severity of the stroke is more, number will be less. Say for an example, if a patient is having infarct in M1, M2, M3, and M4, M5, M6, it will come around 6. So 10 minus 6 is equal to 4. That indicates severe stroke. Okay, depending on the aspect, as the score of aspect is decreases, severity of the stroke will be more.
Sir, M1, M2, M3, these are branches or something else?
Branches of middle cerebral artery.
Okay.
Okay, otherwise you can remember the M2 is almost adjacent to your insular cortex. Okay, at the basal ganglia level, you divide the city as ganglionic level and supraganglionic level. Okay, at the ganglionic level, caudate, insular, internal capsule, lenticular, and insular. This is insular cortex. This is internal capsule. This is lentiform. This is caudate. Okay, adjacent to the insular cortex is M2. In front of M2 is M1, and in like posterior to M2 is M3. Okay, above M1 is M4, above M2 is M5, above M3 is M6. Total 10 quadrants.
Yes.
Okay, total normal points would be 10. If patient is having infarct, you minus adjust. If patient is having infarct in the two places, aspect score will come around 8. If patient is having infarct in all the sites, like 1, 2, 3, 4, 5, 6, 7, you minus it from 7, so it will come around 3. So as the number decreases, severity of the stroke will be more.
Yes.
Sir, these are hypodensities which are seen, sir.
Hypodensities in the CT scan.
Sir, this we are getting it done before 6 hours, sir. Will hypodensities will be visible at that time?
At the some initial it will take time, but some of the like farm stroke, evolved stroke, major stroke, you can make out.
Yes, sir.
Okay.
Sir, how to differentiate from previous strokes or old stroke if it is there?
Old stroke will be like at least two hypodensity will be there, na?
Yes,
Like
sir.
hyper, you normal density 3 will be there. In form, like it will like chronic stroke, it is almost equivalent to your ventricle, like this kind of hypotension will be there. In acute ischemic stroke, there will be some loss of gray white differentiation will be there, large MCA occlusion will be there, and sulcus visibility will be less, edema will be there. These are the acute changes: edema, sulcal invisibility, and gyre and sulcal differentiate. This sulcus and gyre usually normal city you see here.
Yes, sir.
Here sulci are visible, no?
Yes, sir.
Yes, sir.
This
Yes,
sulci are visible, and gyrus and cortical and subcortical differentiation will be there in clear cut. In an acute stroke in a city, you need to see for sulci gyre visible or not, edema is there or not, cortex and subcortical tissue can be able to differentiate or not, or any dense MCA, like large vessels occlusion. If dense MCA is there, this kind of vessels you see, no, here
Yes,
yes,
dense
sir.
MCA. These are the subtle sign, cortical ribbon sign, dense MCA signs. These are the subtle acute signs of the acute, like earliest signs. Even it looks normal. First, you have to see the patient clinically. Okay, if we make the diagnosis clinically, it would be easier to identify the sites. Say for an example, if patient is having features of aphasia, gaze preference, right hemiparesis, patient almost will be having these M1 to M6 occlusions will be there. If patient is having complete hemiplegia, facial palsy, most of the time you need to see for internal capsule. Internal capsule patient will be a complete hemiplegia, right? No, 0
Yes,
by 5 power will be there because confluence of all corticospinal tract.
yes,
Okay. So
yes, sir.
depending on first clinically you see, in fact in the corona radiata, power will be like almost subtle weakness will be there. If patient is having subtle hemiparesis, most of the infarct will be in the subcortical, this internal, this corona radiata. If complete weakness is there, internal capsule. If large visual occlusion clinical features are there, M1, M2, M3, M4, M5, M6 occlusion, these hypodensities will be seen. You should see carefully. Okay. So whenever you receive the patient in emergency, see the setting and mention the infarct, you calculate the aspect score. Okay. If the aspect score is like normal, like as the number, if normal score is will be around, normal score is 10. If score is less, lesser the score, severity of score stroke will be more.
Yes, sir.
Understood?
Yes, sir.
If anybody having doubt, clarify, because this is basic, you should be knowing. In an emergency, you will be seeing the cases. If needed, I will repeat.
sir. If CT is fully normal, then we give 10 out of 10, sir.
10 out of 10 if
Okay.
city is normal.
Yes.
Usually city to like some subtle small stroke, it will take time around minimum 6 hours it will take.
Yes, sir.
City aspect, this is called city aspect, because to MRI it will take like half an hour to 45 minutes it will take.
Yes, sir.
Time window will be less if patient comes within the period of thrombolysis. If keep on doing all MRI, all those things, it will take time. So this is the easiest method to detect the severity of the stroke. Okay, this is for your anterior circulation. Okay, like ACMI and MCA strokes. If in case of posterior circulation stroke, here also you need to calculate the aspect. So this is called PC aspect, that is posterior circulation aspect score. Here we'll give 1 point each for thalamus, one-sided thalamus 1, other side 1. Okay, for occipital lobe 1, cerebellum 1, pons 2, and midbrain 2. Okay, so it will come around for thalamus total 2 points, for occipital lobe 2 points, for cerebellum 2 points, midbrain 2 points, and pons 2 points. It will also come around 10 points only. Okay, if a patient is having only thalamic infarct, you will minus it from 10. It will come around 9. If patient is having bilateral cerebellar infarct, you minus 2. It will come around 8. If only isolated midbrain infarct, you minus 10, 10 you make it, you subtract 2 from the 10, so it will come around 8. Okay, is that okay? If anybody is having doubt, clarify it now only, because most of the time when we are in an emergency, we'll get CT scan only. So from the CT scan only we can assess the severity of the stroke.
So one number only for each, or sir, two numbers, sir?
One for each lobe. If both the side thalamus are affected, it will come around 2 points. Both the occipital 2, both the cerebellum 2. For entire midbrain and pons, they are given 2 points. If small infarct or big infarct, they are given 2 points. For midbrain 2 and pons 2.
Yes. Okay.
Any doubt?
No, sir.
Okay. And third one is modified ranking scale, MRS. As all of you know, most patients we are using, like for follow-up patients or any disability, all those patients we use MRS score. This is called modified ranking scale. If it is 0, no symptom. If it is 1, non-significant disability. MRS 2 is slight disability, but patient can able to manage his routine activities without using any objects or without using any family members. This is MRS 2. MRS 3 is moderate disability. He needs some support for his routine ADL. For MRS 4, patient needs one person support for his routine ADL. MRS 5 is bedridden. MRS 6 is dead. These you should be knowing. Okay, for any stroke patient or any chronic meningitis, chronic follow-up patient, you can label it as MRS scoring. So whenever worsens, you can label it. If, say for an example, patient was having MRS 3 in the follow-up, he went for MRS 5, it indicate there is some new changes might have occurred in his patient. Okay, so whenever you are doing OPD or emergency, mention MRS scoring for all the patients. Okay, any doubt in MRS scoring?
No, sir.
No, is that clear?
Yes, sir.
Okay, so we'll come to the mechanical thrombectomy. What are all the indication for mechanical thrombectomy? Age is more than 18 years, because less than 18 years there are no proven trial for even thrombolysis or for mechanical thrombectomy. Age should be the criteria. Age should be more than 18 years, and our NIHS score should be more than 6. It indicates patient should have major stroke. And time to groin puncture, ideal would be the less than 6 hours, but newer trial says up to 6 to 24 hours. 6 to 24, their new trials have also come. They are telling up to 24 hours we can do mechanical thrombectomy if the penumbra is more as compared to the ischemic core. Okay, and good pre-stroke functional status, that is your MRS scoring should be less than or equal to 2, and your aspect score should be more than equal to 6. And on angiography, if proximal intracranial arterial occlusion should be there. These are all the candidates, ideal candidates for acute endovascular stroke therapy. Okay, these are the class 1A indications. Okay, these you should be remembering. In the exam they might ask if intervention the indications for mechanical thrombectomy, you should be remembering these 5 points. Okay, other indications, class 2 indications are up to 24 hours, and class 2B indications are even distal arterial occlusion, PCA territory. If the aspect score is less than 6, NIHS in 6 less than 6 also we can do, but level of indication would be class 2. These are the above mentioned the class 1A recommendation you should be knowing. Okay, multiple trials have been done till now. Named trials are Mr. Clean, Escape, Riverstat, Swift Prime, Extend 1A, Trace. These are all studies done first 6 hours, and Dawn and Diffuse trial they have done 6 to 24 hours. Okay, Dawn and Diffuse you need to remember, all other things are not much important. Okay, go back to the history, past back history. In 1999, they started with intra-arterial fibrinolysis by using urokinase. Due to the hemorrhagic conversion and a lot of complication, they stopped doing. Then in 2003, they started doing with ultrasound probe guided mechanical thrombectomy. And in 2005 to 8, they did coil retrievers. And 2009 to 12, they used aspiration devices. And recent trend would be stent retriever. These are the stent retriever devices. They used to put inside the vessels, and they used to retrieve the clot, whatever the acute clot that is formed in the large vessels. Okay, these trials are not much important. Okay, these are the two trials you should be knowing. Just you remember the name, there is no need of remembering long form. Okay, Dawn, DAWN Dawn trial, they have included the patient those who presented to the casualty with the duration of history 6 to 24 hours of the stroke. Diffuse 3, they have included the patients of 6 to 16 hours. Okay, less than 6 hours you directly take patient for mechanical thrombectomy if patient is having large well occlusion. 6 to 24 hours you need to um, see per the criteria that are mentioned in the Dawn and Diffuse trials. Okay, Let us know one by one. Dawn and diffuse. These two terminologies you should be knowing. Dawn for 6 to 24 hours. Dawn for 6 to 24 hours. Diffuse is 6 to 16 hours. Any doubt till now? If you have any doubt, kindly ask me.
No, sir.
Okay.
Yes.
Let's come to the diffuse 3 trial. In these trial, they have included the patient, those who presented to the stroke emergency within 16 hours of the stroke, 6 to 16 hours of the stroke. Patient NIHS score should be more than 6, and baseline modified ranking scale should be 2 or less than 2. That is only mild disability. And on angiography, patient should have intracranial occlusion, ICR M1 segment. And they have done the CT perfusion. As I told earlier, CT perfusion scan, the ischemic core volume is less than 75 ml, and penumbra to ischemic core volume ratio is more than 1.8, or penumbra minus ischemic core volume more than 15 ml. It indicates penumbra should be more than your ischemic core. Okay. Mismatch ratio, the penumbra divided by ischemic core 1.8, that indirectly indicate penumbra is more. Mismatch one, that penumbra minus ischemic volume is more than 15 ml, that also indicate penumbra tissue is more. Okay. And age should be more than 18 years. Is that clear?
Yes, sir.
Okay. Mainly, if a patient presented the casualty more than 6 hours, you have to do CT perfusion scan. In that, ischemic core is less than 70 ml, ratio is more than 1.8, mismatch volume is more than 15 ml. If the patient age is more than 18 years and patient is having intracranial occlusion, in this all the criteria meets, then you can ship the patient for mechanical thrombectomy. This is the diffuse tree trial for 6 to 16 hours of the patient. Okay. Next one is Dawn trial. Patient, those who present to the casualty within 6 to 24 hours. And here they have taken the patients of NIHS score more than 10, MRS score 1 or less than 1, and they have done clinical core mismatch. Ideally, the thought is that if a patient is having NIHS score more than 15, infarct volume should be more than 56 ml. Ideally, if a patient comes to the emergency, his NIHS score is 15, it indirectly indicates patient should have infarct volume of more than 56 ml. If the NIHS is 8 to 13, the infarct volume will be more than 32 ml. Okay. Here they compare, if the NIHS score is more and infarct volume is less, that indicate penumbra, there is a tissue of penumbra, existence of penumbra will be there. Okay. Usually here lower mentions I have told that if NIHS is one, if patient is having NIHS of 1 to 7, patient will be having 8 ml of infarct volume. Okay. If 8 to 13, 32 ml. In more than 15 NIHS, patient will be having 56 ml. Okay. They will do CT perfusion scan. Clinically, we examine the patient if the NIHS is more than 10, but the infarct volume is very less, like 21 ml. It indicate penumbra tissue is more. Okay. NIHS score is indicates the clinical severity. If the clinical severity is more, still the infarct volume is less, that indicates penumbra tissue is still salvageable tissue is there. Okay. Any doubt in this slide? Only
No,
these two trials you should remember. Okay. Any doubts?
no, sir.
No? Shall we go?
Sir,
This
can you
concept is like if the severity of NHS is more, infarct volume will be more. Okay.
if there is,
NHS is more than 15 means 56 ml should be their infarct volume.
yes, sir.
If it is less than this means there will be a penumbra tissue. So that is the salvageable tissue. Okay. In
Yes.
that case also we can send patient for mechanical thrombectomy.
This infarct volume is determined through CT, sir.
CT perfusion. Initially I
perfusion.
told you CT perfusion scan. This is
Yes.
nuclear medicine. Like PET scan, na? Like
Yes.
CT perfusion scan is also CT perfusion. There are separate softwares will be there. In a CT machine they have installed, and ideally we have to give contrast also. We have to see per cerebral blood volume, cerebral blood flow, and mean transit time. These are the 3 parameters. They will take the patient, give the contrast, and they will submit the patient for CT perfusion. Automatically the software will calculate the CBV, CBF, and mean transit time, and it will give the exact value of penumbra and ischemic core. Okay. If the ischemic core is more than penumbra, there is no need of doing mechanical thrombectomy. If the penumbra is more than ischemic core, you can ship the patient for mechanical thrombectomy. All these should be done under the CT perfusion scanning. Okay.
Yes, sir. So this clinical core mismatch according to age, this is how do we get this, sir? What does it mean, sir? NIHS score
These
more
mean
than
they
10?
have, like, again, they have classified as less than 80 years and more than 80 years. Again, if I put those slides, it would be difficult for you. Like less than 80 years, 80 more than 80 years. Again, they divided the NIHS score, and these infarct volumes they have put in a different age group. Okay, better you don't remember the age group. Okay, just you remember clinical core mismatch.
Yes, sir.
This is for less than 80 years. This is for more than 80 years. Again, this is for less than 80 years.
Okay, sir.
Okay, because in a age group, like limit, as the age progresses and the duration progresses, rate of outcome will be 4. They have put the age along with your NIHS scoring. Okay, just you remember clinical core mismatch 10, 10 to 19, more than 20, and infarct volume. Okay,
Yes.
this concept you got it, no? Clinical core mismatch means clinically patient is very unstable, but ischemic core is very less.
Yes.
Clinical core mismatch. Okay,
Definitely.
ideally mismatch should not be there. If the patient come in a very late stage, infarct would be formed and penumbra will not be there. In that, there will not be any clinical core mismatch. Whatever the symptoms you are getting, it will correlate with your CT scan or MRI score. If it is clinical core mismatch, that indicate there is some penumbra tissue, that is salvageable penumbra tissue, that is making this clinical core mismatch. Okay.
Yes, sir.
Okay, got it.
Yes, sir.
Any
Got
doubts, ask me. Okay,
No.
little complicated, but you should be knowing. Okay.
Yes, sir.
In posterior circulation also multiple trials are there, but one is best trial, basic trial, BOACHE trial, and attention trial. These are the 4 trials uh, done in the posterior circulation stroke. Okay, even in posterior circulation stroke also we can do mechanical thrombectomy. Okay, you remember these 4 names. Okay, no need of details. Let us come to the procedure. Okay, there are 2 types of, one is stent retriever devices and aspiration devices. Here, these are the first. Coil retriever as the oldest one. Here it contains, this is the first diagram of coil retriever. This is nitinol shape. This is they call this one as a memory wire. It will loops around the thrombus and it will retrieve back to the catheter. In this, patient will be having chances of embolism from this clot. It will retract from this retriever and it will go distally. Sometimes it will have chances of a restroke. Okay, this is the oldest. This is coil retriever. Second was aspiration devices. They will put the aspiration devices directly to the thrombus and it will get aspirated by the negative suction pump. In this setting also patient will be having restroke. These are all the old devices. Newer, recently what we are using now are stent retrievers. This one is the self-expanding stent. It will go distally and it will form bag-like structure and completely it will retrieve the thrombus. Okay, these are the common stent. Nowadays we are using stent retrievers. Okay, let us come to the total like procedure of this mechanical thrombectomy. Say for an example, patient come to the emergency. You have done the CT scan. Patient come within the 4.5 hours. You have done the thrombolysis and you submit the patient for CT angiography. Okay, if CT angiography shows uh, large visual occlusion, and if a patient comes within the 6 hours, you can directly ship for intervention. Say for an example, if a patient comes beyond 6 hours, you need to do either CT perfusion or distal subtraction angiography. In that, patient met the criteria of Dawn or diffuse trial, like penumbra is more than ischemic core. That time also you can submit him for mechanical thrombectomy. After procedure, again you can do either CT perfusion or distal subtraction angiography. Okay. Any doubts? Overall procedure, I am taking this one. Any doubts you can ask.
Sir, you first thrombolyze and then take up for mechanical thrombectomy.
But if patient comes within 4.5 hours.
Yes, sir.
Okay, if patient come within 4.5 hours, you need to thrombolyze. Okay, there is no way, you have to thrombolyze. You see for the indication and contraindication for the thrombolysis, you thrombolyze the patient. Don't wait for all these angiography, perfusion, scanning. Okay, first you thrombolyze the patient and
Yes.
then you submit for CT angiography. Okay, If
Sir,
CT angiography shows any large vessel occlusion, you go ahead for next process. If CT angiography shows only small vessel occlusion, there is no need. You can shift the patient to ward and you can take care of them. Okay. If the patient is having large vessel occlusion and comes within first 6 hours, you can directly do mechanical thrombectomy, because in a first 6 hours there is less chances of development of ischemic core. In the first 6 hours, penumbra tissue always it will be more. They says that if a patient comes within 6 hours, don't do CT perfusion or digital subtraction angiography. You directly shift patient for mechanical thrombectomy. Okay. If patient comes after 6 hours only, you need to see for the salvageable tissue by CT perfusion or digital subtraction angiography. Then you can submit him for mechanical thrombectomy.
sir, do we have to wait for renal functions before taking up for CT angio? Or we can directly do
If they are saying like even CKD patient also, you need to do the contrast study, because if you don't treat, patient will large vessel occlusion, patient will be lifelong bedridden, morbidity will be more.
Yes, sir.
You had seen like large malignant MCI infarct, complete hemiplegia, aphasia patient. If you don't treat, patient will be bedridden for a lifelong. He will be bedridden. If you're seeing nephrons, okay, better you do contrast study even in CKD patients also. It will not harm much. Like a benefit will be more in this setting. Okay, if you do the mechanical thrombectomy, ideally patient will start walking. He will become normal completely. Like we wait for like if you are like thinking for your renal functions or renal kidney failure, if you're thinking about kidney failure, again patient will be bedridden for his life, full of life. So better you do contrast study, even create is more also.
Yes, sir.
Clear?
Yes, sir.
Any doubts, ask me, no problem. Okay. Okay, ideally the blood pressure should be maintained between 150 to 180 mm of Hg prior to the reperfusion. This procedure can be done in general anesthesia with conscious sedation by using ketamine. Post procedure blood pressure should be less than 140 mm of Hg. Just you see the video, okay? Mechanical thrombectomy video.
This animation shows how we perform stroke intervention in patients. When a patient is having a big stroke, there's typically a blockage of one of the major blood vessels in the brain. The blockage is often caused by a blood clot that forms somewhere else, like in the heart or in the carotid artery in the neck, and then breaks
Sir,
off,
video is not visible.
travels up,
Not visible.
and plugs up one of
You
the
know,
main
audio is
blood
audible.
vessels in the brain.
Audio is audible.
So only audio is there, sir. Video we are not able to see, sir.
Not able to say. Okay. Now can you able to see?
Shows how we perform.
Now?
No, sir.
Now also you are not able to see.
No, sir.
Only audio is visible. Audio only.
Yes, sir.
Stroke intervention
Now?
in patients. When a patient is having a big stroke, there's
Can you able to
typically
see?
a
No,
blockage.
sir.
Not able to see?
No, sir.
Amir, just you open the PPT I shared in the WhatsApp group. No?
Sir, generally the audio won't be visible. The video won't be visible, sir.
Okay, we'll see. After class, okay, I will send the video. After class, we'll see. Okay.
Yes, that will be better, sir.
Okay. Come to the limitation. Okay. Only an estimated 10% of the patient with acute ischemic stroke have a proximal large artery occlusion in the anterior circulation. most of the patients will be having, like almost 80 to 90% of the patient will be having small vessel occlusion. And in 9% of the patient presenting in the 6 to 24 hours time may qualify the mechanical thrombectomy. Say for an example, if you take the 100 patient, those who come with a large vessel occlusion, after applying your diffuse or Dawn trial, only 9 to 10% of the patient will meet the criteria for mechanical thrombectomy. And all of us know only few stroke centers, they are doing the mechanical thrombectomy. Even in, I think in Shivamogga, Davangere, Hubli also they are not doing. Only way to send the patient is to Bangalore. Bangalore, I think 4 to 5 centers they are doing mechanical thrombectomy. These are the limitation for mechanical thrombectomy. Any doubt regarding mechanical thrombectomy? Let me know. We'll go for carotid artery stenosis.
Sir, why this cutoff of 24 hours is kept, sir? If it is done after 24 hours, what will happen?
There still studies are going on. Whatever the studies till now they have done, only up to 24 hours. The Dawn trial that has come in the last year, they have taken the patient till 24 hours. Still no studies are going on. Up to 72 hour studies are also going on, but results not yet come. The results whatever come for the patient, those who are having stroke within 24 hours of onset.
Okay.
I think it may come in the future also. Okay.
Yeah.
Currently only approved treatment till up to 24 hours.
Okay.
Shall we go, or are you people having any doubts?
No, sir, no doubt, sir. Continue.
Let us briefly look about the carotid artery stenosis. As all of you know, multiple patients, like after stroke workup, you might be like after carotid artery Doppler, you will get like stenosis, occlusion, this much percent of the blood. Lots of doubts will be there, especially when we are doing MD medicine. Just I briefly tell about carotid artery stenosis management. Okay. Ideally, carotid artery stenosis will be treated by carotid endarterectomy. Most commonly used procedure is carotid endarterectomy, and carotid stenosis will be done in the following mentioned condition. The following mentioned conditions, these are all contraindication for carotid endarterectomy. Okay, in these conditions, we can do carotid artery stenting. Except other condition, the procedure of choice would be carotid endarterectomy. Okay. And carotid artery stenosis is the following: like patient is having congestive heart failure of NIHS 3 to 4 and ejection fraction is less than 30%. Patient is having persistent anginal plain, contralateral carotid artery occlusion, recent myocardial infarction, and recurrent stenosis after end arteriectomy, and prior radiation to the neck and short necks. These are all the contraindication for carotid end arteriectomy. Most commonly used procedure is carotid endarterectomy. These are the following are contraindication for carotid endarterectomy. In this settings, we can do carotid artery stenosis. Okay, carotid artery stenting. As all of you know, cardiac stenting they will do carotid, like they will do carotid stenting also. In carotid endarterectomy, they will remove the affected endothelial tissue and they will make the narrow. They will treat the narrowed lumen by doing the endothelial by debriding the damaged endothelial tissue. Okay, any doubts?
No, sir.
Okay, these are all the most commonly done procedure is endarterectomy. These are all the contrast indication for endarterectomy. In this setting, we have to do carotid artery stenting. Okay, these are the conditions you should be remembering. Carotid artery stenosis, usually they will ask question. Okay. Okay, if a patient comes with the emergency with a stroke, previous history of stroke within less than 6 months, okay, this is called symptomatic carotid artery stenosis. If a patient is having, say for an example, if a patient is having right carotid artery stenosis, patient will be having right MCA or ACA occlusion. So patient will be having left hemiparesis, left hemiplegia. That correlating carotid artery stenosis less than 6 months of your diagnosis of carotid artery stenosis is called symptomatic carotid artery stenosis. Okay, you classify the patient routinely for a procedure. If you have done carotid artery Doppler, that is non-symptomatic patients also you will get that Doppler done, and in symptomatic patients also you will get the Doppler done. In the both way, the management is different. Okay, say for example, patient come to the emergency, you diagnose the stroke, right MCR, MCA, ACA territory infarct. you advise the patient for carotid artery Doppler. Okay, in a carotid artery Doppler, the correlated side, patient is having complete occlusion, repeat is 100% block is there. In that setting also you cannot do surgery, because in a complete occlusion, patient will be having ample number of collateral supply. If you suddenly open the collateral, there will be chances of rupture, and again restroke chances will be there. In a patient with 100% occlusion, there is no need of doing any surgical, only best medical therapy is advised. Okay, in the scenario, if a patient having stroke but carotid artery stenosis is less than 50%, even though patient is having symptoms of stroke, you should not do carotid artery endarterectomy or stenting. In that also only best medical therapy is advised. And the one more scenario is, if the stenosis is 50 to 69% and patient is having stroke, signs and symptoms of stroke, yes, you have to do carotid endarterectomy, but level of evidence is class 2A. Okay, class 2A recommendation. If a patient is having more than 70% till up to 99%, this is the class 1 recommendation. Okay, uh, you receive the patient, you have done the carotid artery scanning, patient is having 70% of the block, you directly refer him for carotid endarterectomy as soon as possible. As guidelines says, better within 2 weeks of onset of a stroke, if you do the carotid endarterectomy, prognosis will be better. Okay, any doubts?
No, sir.
Clear?
Yes, sir.
Complete occlusion, less than 50% occlusion, 50 to 69% occlusion, 70 to 99% occlusion in a symptomatic patient. This one is symptomatic patient. Okay,
Yes, sir.
for an example, patient not having any symptom, incidentally you got the carotid artery done for some fitness purpose or any like thyroid surgery, all those things. If you have got done the carotid artery Doppler, that time if any complete occlusion you have noticed, again only best medical therapy is advised. If again less than 60%, in an asymptomatic person, patients with stenosis of less than 60%, it is also only for medical line of management. If a patient having 60 to 90% of occlusion, not any prior history of the stroke, again you need to decide if a patient expectancy is more than 5 years, and surgical sites like neck anatomy, existing severe cardiac illness, all those things are there. And if a patient is having high risk for stroke, like hyperlipidemia, uncontrolled diabetes, hypertension, family history of stroke, old stroke, family history of stroke or cardiac illness, if it is there, again you need to tell the patient for need of surgery. Here the level of indication is 2. Any doubt? If you have
Sir,
any doubt, ask me.
sir, can this be carotid endarterectomy be done in the same setting as mechanical thrombectomy, sir?
Mechanical thrombectomy on that side only you have to do. No? That is correlating stroke should be there.
In the same setting, can it be done, sir, if it is identified?
No, it is like stroke is secondary to carotid artery stenosis. Mechanical thrombectomy, no, we cannot do. Mechanical thrombectomy is only for intracranial large vessel occlusion. It is for extracranial, time will be up to 2 weeks. You can be send, you can send for a patient.
Okay, sir.
Same setting you cannot do. Same setting. You are telling like ICS stenosis and large vessel occlusion at a time in the same patient.
Yes, sir.
If a patient is having large vessel occlusion and carotid artery stenosis,
Yes, sir.
in that setting, ideally first should be treated as your intracranial atherosclerosis. Mechanical thrombectomy should be done first, because both procedures are different. No,
Yes, sir.
this carotid artery stenting is different, endarterectomy is different, embolectomy, thrombectomy is different. Thrombectomy, they will remove the thrombus, whatever the occluded thrombus is there, they will remove. In carotid artery stenosis, they will put the stent, or they will remove the damaged endothelial tissue.
Yes, sir.
And the time period would be up to 2 weeks, would carries better prognosis. There is no hurry in like stroke happened, now only we have to do stenting. No, you can, up to 2 weeks you can do surgery, carotid arteries.
Okay, sir.
Okay, in a asymptomatic patient, if block is more than 60%, life expectancy is more than 5 years, favorable anatomy is there, and patient is having higher risk factors for the future stroke, in that setting you can advise him for carotid artery stenting or carotid endarterectomy ideally.
Okay, sir.
Any doubts?
No, sir.
This is very important because they will ask you carotid artery stenosis commonly you are seeing. For all stroke patient, you need to get carotid artery done, detailed cardiac evaluation, and vascular like angiography of the brain, neck vessels, all these things you should get it done because these are all for future prevention of the stroke. If patient comes with stroke, you treated, you send the patient, again he will come back if patient is having any severe carotid artery stenosis. You need to advise whenever patient comes, you need to evaluate whether patient is having lacunar infarct, small vessel occlusion, large vessel occlusion, or patient having carotid artery disease, or patient having cardiac issues. These all the things should be ruled out whenever the ischemic patient comes to your ward. So future prevention of the stroke will be in your hand. Shall we go ahead?
Yes, sir.
We'll go to summary. Okay. You are in emergency. A patient comes with acute ischemic stroke, acute hemiparesis or hemiplegia, dysarthria. You have done the CT scan. You diagnosed it as ischemic stroke. Less than 4.5 hours. You calculate the NIHS. Okay. If NIHS score is 0 to 5, it is indicates the minor stroke. If NIHS score is more than 6, indicates major stroke. Okay. Let us come to the minor stroke. Again, you need to divide the minor stroke as disabling stroke and non-disabling stroke. I tell an example. If a 85-year-old male patient presented with an emergency, just he is having the weakness of his fingers, that is not a major disability for him. If a patient, young patient, or if a surgeon, or if a driver, he is having the weakness of the fingers, is disabling for him. Okay, you need to decide the deficit is disabling for him or not. You need to decide. If patient is having only hemianopia, older age, like 80 years and old age patient comes with hemianopia, it will come around NIHS 2. But still, some patient like for ophthalmologist, for surgeon, again it will be disabling. If hemianopia is there, it would be difficult for surgeon to operate the condition. So that is disabling for the patient. So deficits are disabling according to the person. Okay, you decide whether the minor stroke is disabling for him or not. If it is really disabling, you go ahead with the thrombolysis. If it is not disabling for the person, you give the dual antiplatelet for 21 days and statins along with, and immediately you start the antiplatelet whenever you receive the patient. Okay, if disabling is there, you thrombolyze the patient. After after 24 hours of thrombolysis, you start with single antiplatelet. Okay, again patient is having more than NIHS 6, you thrombolyze the patient. After 24 hours, if no hemorrhagic conversion, you start the antiplatelet. Is this clear? 4.5 hours, less than 4.5 hours. Any doubts?
Yes, sir.
Okay. If a patient comes within 4.5 hours to 24 hours, again you divide less than 6 hours and 6 to 24 hours. In less than 6 hours, you see per criteria for mechanical thrombectomy. If NIHS is more than 6, aspect is more than 6, you give the patient for mechanical thrombectomy without doing any perfusion scan studies. Okay. And one scenario on come, patient attendant brought to the hospital in a wake up stroke condition, where patient slept around 10:30 to 11 morning. Attendants notice patient is having some deficit, they have come to the emergency. That time you need to do, ideally you need to do MRI, you need to see for diffusion flare mismatch. Diffusion flare mismatch is there, again patient would be ideal candidate for thrombolysis. Okay, if diffusion flare mismatch is not there, patient cannot undergo thrombolysis. Again, medical line of treatment you have to do. Okay, any queries in this 4.5 to 6 hours?
No, sir.
Clear?
Yes, sir.
Okay. Next come to 6 to 24 hours. If a patient comes within 6 to 24 hours, Again, you apply this for diffuse and dawn trial. 6 to 16 hours diffuse trial. These two trial parameter I told earlier. Okay, you just go through the parameters: NIH score or MRS score, perfusion values, clinical core mismatch, or city penumbra ischemic core ratios. All those things you have to see. If a patient met the criteria of diffuse and dawn trial, you can send patient for mechanical thrombectomy. Is this clear? 6 to 24 hours.
Yes, sir.
Okay. If the patient comes after 24 hours, you diagnosed as large vessel occlusion. Okay. Large vessel occlusion, again, you cannot do any mechanical thrombectomy. You need to give the medical line of treatment. If you find carotid artery stenosis, as I told earlier, depending on symptom, depending on amount of blockage, whether it is 70 to 99%, or 60 to 70%, or 50 to 60%, you need to see the carotid artery amount of stenosis that happened. According to that, again, you need to manage the carotid artery. Large vessel, intracranial large vessel occlusion, again, you cannot do anything. You have to do medical line of treatment. If patient diagnosed cardioembolic, patient is having LA clot or atrial fibrillation, or your MRI findings or CT findings suggest to a cardioembolic territory infarct, you need to start with anticoagulant. Okay, this anticoagulant and antiplatelet I will take in the next class. Okay, Diner's rules will come, European guidelines are there. These I will tell in the next class. Okay, is that clear? More than 24 hours?
Yes, sir.
Hmm?
Yes, sir.
Or can anybody repeat this one? One Pallo repeat 4.5 hours, one 4.4 to 24, and more than 24. You see the slides and just explain. This is very important. All of you should be knowing this. Voluntarily tell, no problem. Okay.
With signs and symptoms of stroke comes within less than 4.5 hours with
Hmm.
a NIHSS score of 0 to 5. We should say whether the signs and symptoms are disabling or non-disabling.
Okay.
If they are disabling, like a person is very needs skilled working and that
Hmm.
kind of
Hmm.
disabling things there,
Hmm.
and if he presents within less than 4.5 hours, we can go for thrombolysis. And then
Okay.
single antiplatelet to be started within 24 hours and statin should be given. If
Okay.
it is non-disabling, then for NIHS score of 0 to 5, there is no need for thrombolysis. We can directly start with dual antiplatelets for 21 days and within 24 hours with statins.
Okay.
And if the patient presents like within 4.5 to 24 hours, then
Hmm.
we should divide it. Then if he presents within 6 hours or after 6 hours. If they
Yes.
present within 6 hours, then we should calculate NISS score, aspect score, and see if the intracranial
Artery
arteries
occlusion. Hmm.
occlusion is there, or M1 or M2 occlusion is there. If it
Hmm.
is more, if those two scores are more than 6 and this distal IC occlusion is there, then we should go for mechanical thrombectomy. And
Okay.
if we don't know the patient, the exact time when the stroke onset,
What
or if it
happened?
is a wake up stroke, then we
Hmm.
should go for, we have to get a DWI flare, MRI should be done.
Hmm.
And in that,
Can you tell me the concept of DWI flare mismatch? What does it indicate?
penumbra and ischemic area mismatch.
Can anybody tell? DWI flare mismatch, as I told earlier. This is very important.
Ischemic area to penumbra mismatch if it is present.
No, DWI flare, that is city perfusion.
Awesome.
Ideally, for stroke, you will do DWI ADC. You know, na? Hello?
Yes,
Yes,
sir.
sir.
Yes, sir.
Diffusion weighted, usually hyperintense signal will be there, and ADC hypointense signal will be there. It indicates acute ischemic stroke, that is cytotoxic edema. Okay. DWI you see. Meanwhile, you have to see for flare images. Okay. In flare images, if hyperintense signal is there, that indicates in a flare image to develop edema and hyperintense signal, it will take minimum of 4 to 5 hours.
Yes, sir.
Only DWI images showing infarct, flare is normal, that indicate still patient is under window period. If DWI showing stroke, again flare images showing edema, that indicate already stroke has formed stroke, that indicate already crossed window period.
Yes, sir.
Edema to develop in a flare image, it will take 4.5 hours. Okay,
Okay, sir.
is that clear?
Yes, sir. Yes, sir.
Because this is very important. Like early morning patient will come.
Yes,
Okay,
sir.
patient slept around 10 o'clock.
Yes,
In
sir.
between the time 10 to 7, nobody noticed, and patient will not be knowing the
Exact.
stroke. Patient might not be knowing. He might be sleeping, and whenever morning they notice patient had stroke, that time it would be difficult to determine the time. So you do the MRI, DW and flares images. If DWI and DWI signals are there, flare is normal. That indicates stroke is within 4.5 hours. Okay. If DWI signals are also there, flare also hyperintense signals are there. That indicate the window period has crossed. There is a stroke had happened 4.5 hours prior only. Okay. If that mismatch is there, you go again with the thrombolysis. If mismatch is not there, again medical line of treatment.
Yes. Yes,
Out?
sir. Yes.
Is that clear? DWI flare
Yes,
mismatch.
sir. Yes, sir. Clear, sir.
You have
Then,
learned DWI flare mismatch one, clinical core mismatch, and penumbra ischemic mismatch. These are three mismatches you should be knowing.
yes,
DWI flare is in our setting we will do by MRI, we can identify. Ischemic and penumbra core volume and clinical mismatch volume, they will be ideally done with the CT perfusion scanning. Okay,
scanning.
okay, next.
Next, if the patient presents after 6 to 24 hours, we should look for dawn and
Yeah,
uh,
Dawn and
diffuse,
diffuse trials.
diffuse trials. So, like for dawn trial, if there is NIHS score more than 10 and
Hmm.
MRS score less than 1, then for those, if the patient can be taken up for mechanical thrombectomy if presence within 24 hours, for diffuse for less than 16 hours.
Okay. In Dawn, again they have taken penumbra and ischemic core ratios, ischemic core volumes,
Yes.
and penumbra minus ischemic core values. If penumbra is more, you take for surgery. If penumbra is less, ischemic core is more, again best medical line of treatment.
Yes.
Okay.
Yes. Then more than 24 hours, if they have large vessel occlusion and they have presented after 24 hours, then we can, if there is more than 50% of carotid stenosis, we can go for stenting
Again,
of.
large vessels you can divide as intracranial and extracranial. Intracranial large vessel occlusion, you cannot do anything
Yes.
after 24 hours. Okay,
Yes.
only medical line of treatment. Extracranial vessel occlusion, again, I told that previous chart. No, you follow
Yes.
that chart.
Yes, sir. More than
No?
an yes, sir.
Hmm.
If symptoms are present or not present, based on that,
Hmm.
again, then dividing how much level of block is there. If
Block
less
is there,
than
depending on that, you
50%,
can go ahead for the
more
surgical
than
intervention.
yes, sir.
This cardioembolic I will take. Okay, this is again big topic. Commonly, we are antiplatelet and anticoagulants in stroke. Next class I will take. Okay.
Yes, sir.
Is that clear for this guideline should be knowing? Okay.
Yes,
Emergency in and out you are seeing daily you are seeing stroke cases.
yes,
How
sir.
frequently you are seeing in
So
your
daily,
emergency?
daily, sir.
Daily you are seeing. No, just apply this one. Okay.
Yes, sir.
Whatever the possible things in our government setup, most of the time we can't do anything. Thrombolysis also we cannot do. And we can give antiplatelets. We can evaluate the patient for cardiac and carotid artery stenosis. We can identify large or small vessel occlusion in our setting. We can give antiplatelets. So these kinds we can in this setting whatever the possible thing we can able to do we can do. Okay, this table everybody should be knowing. Okay, less than 4.5, 4.5 to 24, more than 24 hours. Okay, if patient really affordable, you advise them. Okay, you take the patient, do the CT, if possible MRI and angio, whether it is large vessel are there or not there. If large vessel is there, if patient come within 24 hours, you tell them for the mechanical thrombectomy in these are the following centers done. The cost, I think mechanical thrombectomy, it will come around 6 to 10 lakhs. It will, if they are really affordable, you thrombolyze the patient, you refer the patient for higher center. If they are not willing, take a consent, patient not willing for further level of management, just only medical line of management is advised and treat accordingly. Okay,
Yes, sir.
clear?
Yes, sir.
Okay. Conclusion, intravenous thrombolysis with IV TPA should be done within 4.5 hours. If treatment can be initiated within 6 hours, there is no need of doing additional images like perfusion studies. Okay, within 6 hours, no need of doing perfusion studies because penumbra will be more compared to ischemic core within 6 hours of the stroke. So you directly ship the patient for thrombectomy. And time window for extra endovascular therapy is 24 hours. Okay. Any doubts?
No, sir.
Sir, next class will be on antiplatelets and everything, sir.
Antiplatelet anticoagulants. Just you look antithrombotics in acute ischemic stroke and transient ischemic attacks.
Okay.
Next Thursday or Friday.
Yes, sir. Thank you, sir.
Thank you. Thank you, sir.
Okay.